Good afternoon, everybody. We'll be starting with our third scientific session. For this third scientific session, I would like to invite Dr. N. Radha, former advisor, Homeopathy, Ministry of Ayush, and Dr. Ashok Sharma, Chief Medical Officer, NFSG, Government of Delhi, as chairpersons. The speakers for the session are Dr. Anil Khurana, Deputy Director General, CCRH, and Dr. Martin Brands, Coordinator of Scientific Committee of Dutch Doctors. I request Dr. Devdutt Nayak, Research Officer, CCRH, to kindly felicitate Dr. Radha. I request Dr. Devdutt to kindly felicitate Dr. Ashok Sharma. I request the speakers, Dr. Martin Brands and Dr. Anil Khurana, to please join us on the dais, please. I request Dr. Deepti to please felicitate Dr. Martin Brands. Request Dr. Deepti to please felicitate Dr. Khurana. I request the chairpersons to kindly initiate the session.
To all of you, all are coming late as enjoying the food. She's saying less. Now, this session, we have two papers. Dr. Martin Brands from Netherlands will be presenting high quality data presentation. As we all know, research, data presentation and the collection of data analysis all are very important. So let us hear from him what he is going to.
Good afternoon. I see this is a Darwinian selection process, who survives lunch. And we are with a selected audience now. I will do my best to enjoy you during your physiological dip this afternoon, which is usually between 2 and 3. I think the staff of CCRH, and in particular Dr. Manchanda, I thank the staff of CCRH, and particularly Dr. Manchanda, to invite us here because I feel there's a great momentum being created in India at the moment, and I hope we can have more cooperation between, let's say, the homeland of homeopathy in Europe and the rest of the world. A few years ago I was in Brazil as well, and I think Brazil and India are really on the front line at this moment in development of homeopathy, both in clinical research and in fundamental research. And I'm very glad that the public health efforts are being so valued here, because homeopathy would not be a serious medicine if we could not reach all of the people who need it. And I'm especially thinking about children. So what we did in the Netherlands was asking ourselves, what is the distance between complementary medicine and mainstream medicine? And there are some gaps between conventional and homeopathy. One is that conventional medicine always talks about diseases related to certain organs or organ systems, and we look to the system as a whole. But systems biology, the very science that deals with the heterogeneity, can help to bridge us this gap. Because also in systems biology, a lot of data are being gathered, and they refer to identify certain patterns of key markers, both on genetic and metabolic level. So in this way, by doing an individual assessment, we may bridge the gap in the future between a generic and a personalized medical discourse. So the emphasis would be for me on the case-based rather than group studies, because RCTs are considered the gold standard in evidence-based thinking, but they work from a more or less idealized situation, is that people are more or less the same, they are homogeneous in groups, and I wonder if it's really needed to go many lengths to try to adapt us to this reality, because in conventional medicine increasingly many authors are openly doubting the external validity of the outcomes of randomized clinical trials. And we, however, can capitalize on our case-based evidence and collect this in a systematic way. So what we try to do is make the bridge between both systematized data and the individual approach, as you will see from the database which we have developed. Because with some people we had, for years we had gatherings in the Netherlands in the beginning of the 2000s about research projects, and actually we got a bit disappointed about the progress of that, because there was no concrete tool to unify a lot of data. And people were talking about doing RCTs, but they didn't get funds for doing them. So we thought, well, we are more or less wasting our time. Let's become practical and let's develop a tool. So what we need, if we have a tool to record confidentially patient data, is that it needs to be open. That means open for those we admit into that community. And increasingly we felt it should be online, because there were different programs and it was always a matter of compatibility between Apple and Windows systems. And daily data should be inserted easily in a user-friendly way. And I and my colleague, we always dialogued, discussed with the programmers, okay, we are not computer nerds, we do not like to sit before a screen for a long time, we just want to have contact with our patients, that's our primary goal in any consultation, but we want to have our data systematically recorded as well. So we wanted to have maximum 10 minutes for a first consultation and 5 minutes for follow-ups, and it should be apt for what we call digibeats, that is the other word for analphabetes. So the last few years we developed a way of working where we've tried to fill the conditions of user-friendliness with community reinforcement, and that we can get feedback from our own practice and from those of others, and that it will be compatible with other medical systems, because we developed this within the heart of our Dutch Doctors Association for Integrative Medicine, and that says already that there are not only homeopaths but also naturopaths, Chinese medical doctors, orthomolecular physicians, and so on. So we wanted really to have a cross-cultural model, so to say. And 2 years ago we made the final move to an online facility, so it can be filled in online, and we can in this way work very rapidly with some specific tools being part of it. So I want to share with you the main steps in the navigation through the database. I'm not sure if the login page will functioning here, but if not, there's no disaster, because I have made screenshots from the most important pages. So we have different roles, and we want those roles to be represented in our work. And I am an individual practitioner. I want to know what I have done the last year or 2 years with certain patients with certain illnesses. Or I want to know, how do I use the remedy sulfur or belladonna in my practice. So I want to have a feedback for my own work. But I'm also a member of a professional group. I want to know what other people do with similar illnesses. And when I get stuck with a patient with asthma, I would like to know what my colleagues did for interventions within my professional group, but also within other professional groups. So that can function as a constant intervision. And the third function we have is that we are representative of our profession, so we can gather individually constructed data in a systematic way, and by that we can generate research questions and projects. So the login page is called PBR, Practice-Based Research. You put in your name. I will see if I can do that with the next slide, because before it didn't work, but maybe now. No, the request is not valid. Okay, so I go on with the next slide, where we have the main data for a patient when we start patient file, that is a dossier, and you have certain. I cannot see how large. I think it's readable from the soul. No, okay. So we can. I will explain you a little bit about the main complaints, previous investigations, accidents, operations, and other diagnostics, and previous illnesses in the family, use of intoxications like alcohol and tobacco, and use of medicines, and other complementary diagnoses. And then we can move to the next screen, which is about the diagnostics. And in my PhD, I have spent quite some time on comparing the symptoms between different complementary medicines, and from there we have made a kind of a generic list which can be applicable in the different forms of medicine. So one you can see here is the complaints. The complaints can be mentioned here. Each complaint has a specific pain sensation and can have some accompanying symptoms, and has modalities, and also has etiology. So these different aspects of one symptom can be worked out in 4 different complaints, which can be listed here. So you acquire kind of a matrix, and already in that way I remind you of Kent, who said that modalities run like a red thread through a case, and in this way these red threads can become visible. The next step is then that we have the features for each patient, and the features can be reactions, key reactions to events in the biography. It can be fears, dreams, memory, concentration, sleep. So we have here the main autonomous functions like menstruation, food preferences, aversions, temperature, climate sensitivity, and also the different histories from the different tracks, and physiognomy. So these features usually are shared by the people that they are part of the patient pattern, and they also are prevalent when someone is not ill. Although these are linked to the disease episodes, these are not. So after scoring these, the different physicians can score the different investigations they do and the different treatments they plan. For example, here you have the physical examination, laboratory, imaging, homeopathic differential diagnosis. For the Chinese medicine, you have tongue and pulse diagnostics. Biophysical medicine, you have measurements of their tests, eventual lack of nutrients, and other naturopathic diagnostics which may have been used. So in this way you can come to a differential diagnosis, and the differential diagnosis includes the main possibilities, the main options which are being used in forms of complementary medicine, but also you will document here what are you advising. What, do you advise any diet, lifestyle, what is your the treatment, and is there any referring intervention you do? So you want someone to be seen, for example, by an acupuncturist or a chiropractor too. A summary of these data is given in this slide, where you can see that you have different diagnostics options, and the advices, dietary, treatment, referring, they are all summarized in a concise matter. So that means that you can have several screens, one after the other, according to the consecutive consultations which your patient goes through with you. So after a while, you can imagine you have different diagrams of these, one after the other, and if you have a long-term treatment, you will have more screens than this. So different diagnoses can be compared: homeopathy, Chinese medicine, naturopathy, and others, and also ICPC code, the International Code for Primary Care, can be involved. And with every follow-up, it's also meant that the patient inserts their satisfaction, and we propose to use the ORIDL because the ORIDL is well correlated with the MyMOP, which is the My Medical Outcome Profile, and these have been used in many international researches. Here it's possible to work out further, because we want that every practitioner feels the liberty to write down specific thoughts and considerations regarding the patient and regarding the treatment. So we don't want to that people feel squeezed in kind of a format where they cannot elaborate on their specific cases. So we have some options here which can be used. And our contact now with the CCRH is as such that we are considering to form digital communities, because the CCRH has many centers in the country, and we can use registration as what they call in public health sentinel surveillance. So certain groups which are already being treated by specific programs from the CCRH can be reached in this way, and monitoring is more possible than without such a system. We also will offer a help desk, and we also will build up an expert team and a researcher from integrative medicine, epidemiologist and a statistician, to be sure that the data are being used for reliable scientific exercises. And the main points for us are that this security of the data storage, so the data are completely safe. A patient gives informed consent and can also at each time he or she wishes withdraw from the database. We have in Holland, we have some legislation regarding the medical treatments, that patient remain the owner, the intellectual owner of their data. We want to respect that. And if there will be any exchange of data between colleagues, that this will go on basis of anonymity. So one of the first screens which I showed you will not be accessible for other colleagues. And only the one who treats, the inserting doctor, can see the patient identification data. And in this way, database fields can be compared to others. So some questions which we are interested in is what is the variation in treatment of a certain illness in the own practice, practice of colleagues, and practice of other forms of medicine. Is there also variation in diagnostic symptoms given a specific problem? But we can expand that also to variation between symptoms in patients which got the same homeopathic remedy. I refer to the work of my colleague Lex Rutten regarding the likelihood ratio, where it's important that you can see if the what is the proportionate prevalence of certain symptoms in one in cases that have reacted well to a certain remedy. What are the results in the ORIDL? That is the outcome scale for the daily impact, the impact of daily life, for both the main complaint and for the general health situation. And is it possible to relate certain results to therapeutic approaches, especially when you have more doctors working on within an association? It's important to know are the specific problems which are well treated with homeopathy, and some are well treated with acupuncture and so on, in order to have a most effective healthcare. And can we distill best practice results on the longer term? Might there be preferential treatments for specific illnesses? And all that requires a rapid survey of data. So research agenda for the coming years can we make a priority list from these data in terms of the heterogeneity, that means the differences between the patients, also in terms of successful practices in certain illnesses. And it will also be possible to have studies in several countries. And we can in this way start studying a series of patients without the usual drawbacks of an RCT. One of is the low external validity, because people entering the study usually have to fulfill quite precise inclusion criteria, while here the essence is to measure in a naturalistic, open situation. And there is enough experience the last 10 years with conducting good open study and observational studies that we can use these to safeguard against too many confounders and biases. I give you just an example.